Question 1. A patient presents with pain and swelling over the radial styloid, exacerbated by grasping and thumb movements, particularly during activities requiring repetitive wrist-ulnar deviation with thumb flexion and adduction. Which special test would most likely confirm the suspected diagnosis? A. Phelan's test. B. Tunnel's sign at the wrist. C. Finkelstein's test. D. Grind test. Answer: C. Finkelstein's test. This question describes symptoms highly indicative of de Quervain's tenosynovitis, a condition affecting the abductor pollicis longus and extensor pollicis brevis tendons in the first dorsal compartment. The key phrase radial styloid, exacerbated by grasping and thumb movements, particularly during activities requiring repetitive wrist-ulnar deviation with thumb flexion and adduction, points directly to this diagnosis. Finkelstein's test specifically provokes pain in the first dorsal compartment by passively stretching these tendons, thereby confirming the diagnosis. For example, a patient with de Quervain's will experience sharp pain at the radial wrist when performing this test. Remember, Finkelstein's test is the classic diagnostic maneuver for de Quervain's tenosynovitis. Question 2. A patient sustained a Call's fracture 6 weeks ago and has been cleared for gentle active range of motion. During a therapy session, the patient reports significant pain when attempting wrist extension, and you observe a palpable crepitus. What is the most appropriate next step for the therapist? A. Progress to passive range of motion exercises. B. Apply a warm pack and continue with active ROM. C. Discontinue ROM exercises and notify the physician. D. Initiate strengthening exercises for the wrist extensors. Answer: C. Discontinue ROM exercises and notify the physician. The concept tested here is recognizing red flags during rehabilitation and knowing when to alter the treatment plan or involve the physician. The keywords significant pain and palpable crepitus are critical red flags indicating potential complications, such as non-union, malunion, or hardware issues, especially after a fracture. Continuing with range of motion, applying heat, or initiating strengthening in the presence of these symptoms could exacerbate the problem or cause further injury. The most appropriate and safest action is to immediately stop the activity causing the concern and communicate these findings to the physician for further evaluation. Always prioritize patient safety and recognize when an activity is causing more harm than good. Question 3. A patient presents with a laceration to the ulnar side of the wrist, resulting in weakness in wrist flexion and ulnar deviation, along with impaired sensation over the palmar aspect of the fifth digit and ulnar half of the fourth digit. Which nerve is most likely injured? A. Median nerve. B. Radial nerve. C. Ulnar nerve. D. Anterior interosseous nerve. Answer: C. Ulnar nerve. This question tests your knowledge of peripheral nerve anatomy and its sensory and motor distribution. The keywords ulnar side of the wrist, weakness in wrist flexion and ulnar deviation, and impaired sensation over the palmar aspect of the fifth digit and ulnar half of the fourth digit are classic signs of an ulnar nerve injury. The ulnar nerve primarily innervates the flexor carpi ulnaris, responsible for wrist flexion and ulnar deviation, and the ulnar two lumbricals, all interossei, the adductor pollicis, and hypothenar muscles. Its sensory distribution covers the ulnar half of the ring finger and the entire small finger, both dorsally and palmarly. For example, damage to this nerve often results in a claw-hand deformity over time due to muscle imbalance. Remember that the ulnar nerve is crucial for fine motor control and sensation on the ulnar side of the hand. Question 4. A patient undergoing rehabilitation for a flexor tendon repair of the third digit, zone 2, is 3 weeks postoperative. The surgeon's protocol specifies early active motion. Which of the following exercises is most appropriate at this stage? A. Passive full range of motion of the involved digit. B. Resistive grasping exercises. C. Place and hold exercises into composite flexion. D. Isolated full extension of the repaired digit. Answer: C. Place and hold exercises into composite flexion. This question assesses knowledge of flexor tendon rehabilitation protocols and appropriate exercise progression in the early phases. At 3 weeks post-op for a Zone 2 flexor tendon repair with early active motion, the goal is to promote tendon gliding without excessive tension on the repair. Place and hold exercises into composite flexion, meaning all finger joints flexing together, are ideal because they allow the patient to actively hold a position achieved passively or with minimal active effort, promoting tendon gliding and preventing adhesions without placing undue stress on the repair site. Full passive range of motion or resistive exercises are too aggressive, and isolated full extension could rupture the repair. For example, gently assisting the finger into a flex position and then asking the patient to hold it there strengthens the repair while respecting its healing. Always prioritize controlled motion and protection of the repair during early healing. Question 5. A therapist is evaluating a patient with persistent edema in the hand following a distal radius fracture. The edema is pitting, but non-blanching, and the skin is cool and slightly discolored. Which modality or technique is most appropriate for initial management of this edema? A. Deep tissue massage. B. Continuous passive motion device. C. Manual edema mobilization, MEM. D. Aggressive active range of motion. Answer: C. Manual edema mobilization, MEM. This question tests understanding of edema management principles and appropriate interventions for specific edema characteristics. The keywords persistent edema, pitting, and non-blanching suggest a more established or complex edema, while cool and slightly discolored might hint at circulatory compromise or early signs of sympathetic dysfunction, though the primary focus is on the edema itself. Manual edema mobilization, MEM, which includes techniques like retrograde massage, lymphatic drainage, and specific exercise, is the most appropriate choice for reducing stubborn hand edema as it effectively moves fluid without causing further inflammation or trauma. Deep tissue massage is too aggressive for acute or subacute edema, continuous passive motion is not a primary edema treatment, and aggressive active range of motion without prior edema reduction could exacerbate the problem. Remember, MEM is a comprehensive approach to managing various types of hand edema. Question 6. A patient reports paresthesias in the thumb, index, and middle fingers, especially at night, and describes dropping objects frequently. Which of the following tests is used to assess the patient's dexterity and functional pinch strength? A. 2-point discrimination. B. Semmes-Weinstein monofilament test. C. Purdue pegboard test. D. Jepson-Taylor hand function test. Answer: D. Jepson-Taylor hand function test. This question assesses understanding of functional assessment tools used in hand therapy. The keywords paresthesias in the thumb, index, and middle fingers and dropping objects frequently strongly suggest median nerve compression, likely carpal tunnel syndrome, which affects dexterity and grip. While 2-point discrimination and Semmes-Weinstein test sensation, the question specifically asks for a test of dexterity and functional pinch strength. The Jepson-Taylor hand function test is a standardized, objective assessment that measures a broad range of fine and gross motor hand functions relevant to daily activities, including writing, simulated feeding, and stacking checkers, which directly evaluates dexterity and functional use of the hand. The Purdue pegboard test measures fine motor dexterity and coordination but doesn't encompass as wide a range of functional tasks as the Jepson-Taylor. Therefore, the Jepson-Taylor is the most comprehensive choice for assessing overall functional hand performance. Question 7. A patient presents with a painful, firm nodule in the palm at the base of the ring finger, which has started to cause contracture of the MCP joint of that digit. The patient denies any acute trauma. Which condition is most consistent with these findings? A. Trigger finger. B. De Quervain's tenosynovitis. C. Dupuytren's contracture. D. Ganglion cyst. Answer: C. Dupuytren's contracture. This question tests recognition of common hand pathologies based on their characteristic presentation. The key phrases painful, firm nodule in the palm at the base of the ring finger, contracture of the MCP joint of that digit, and denies any acute trauma are classic descriptors of Dupuytren's contracture. This condition is a progressive fibromatosis of the palmar fascia, leading to nodules and cords that eventually cause flexion contractures, most commonly affecting the ring and small fingers. Trigger finger involves a catching or locking phenomenon of the digit due to inflammation of the flexor tendon sheath, not a fixed contracture initially. De Quervain's is at the radial wrist, and a ganglion cyst is typically a soft tissue mass. Therefore, the presence of a palpable nodule and progressive MCP flexion contracture without trauma points to Dupuytren's contracture. Question 8. A therapist is fabricating an orthosis for a patient with a boutonniere deformity. The primary goal of this orthosis is to correct which specific joint deformity? A. PIP joint hyperextension with dip flexion. B. PIP joint flexion with dip hyperextension. C. MCP joint hyperextension with PIP flexion. D. MCP joint flexion with dip extension. Answer: B. PIP joint flexion with dip hyperextension. This question assesses knowledge of specific hand deformities and the purpose of orthotic intervention. The concept tested is the characteristic presentation of a boutonniere deformity and how orthoses are designed to address it. A boutonniere deformity is defined by a specific presentation, flexion of the proximal interphalangeal (PIP) joint and hyperextension of the distal interphalangeal (DIP) joint. The orthosis for this condition aims to maintain the PIP joint in extension to allow the central slip to heal and to facilitate active dip flexion to restore balance. For example, a three-point extension orthosis is commonly used to extend the PIP joint while allowing dip motion. Understanding the components of the deformity is crucial for correct orthotic application. Question 9. A patient is experiencing difficulty with fine motor tasks such as buttoning shirts and picking up small coins, along with weakness in pinching. Sensation is intact. Which muscle is primarily responsible for performing true pinch and is likely affected? A. Flexor digitorum profundus. B. Lumbricals. C. Abductor pollicis brevis. D. Adductor pollicis. Answer: D. Adductor pollicis. This question focuses on understanding the primary muscles involved in precision tasks and pinch strength. The keywords difficulty with fine motor tasks such as buttoning shirts and picking up small coins and weakness in pinching while sensation is intact strongly suggest a motor deficit affecting the thumb's ability to exert strong, precise pinch. The adductor pollicis muscle is crucial for strong pinch, specifically, adduction of the thumb towards the palm, which is essential for many fine motor tasks. While other muscles contribute to pinch, the adductor pollicis is the prime mover for forceful thumb adduction, a key component of functional pinch. For instance, a patient with ulnar nerve palsy often experiences weakness in this muscle, leading to a compensatory Froment's sign during pinch. Knowing the specific function of the adductor pollicis helps you identify its role in common daily activities. Question 10. A patient presents with a laceration over the dorsum of the wrist resulting in a wrist drop deformity. Which nerve is most likely injured? A. Median nerve. B. Ulnar nerve. C. Radial nerve. D. Anterior interosseous nerve. Answer: C. Radial nerve. This question tests fundamental knowledge of peripheral nerve innervation and its characteristic motor deficits. The key phrase wrist drop is the classic sign of a radial nerve injury. The radial nerve innervates the extensor muscles of the wrist and digits. Therefore, damage to this nerve leads to an inability to extend the wrist and fingers at the MCP joints, resulting in the characteristic dropped posture of the hand and wrist. Other nerves primarily affect different movements or areas of sensation. For example, if a patient cannot extend their wrist or fingers against gravity, a radial nerve palsy should be immediately suspected. This wrist drop is a direct indicator of compromised radial nerve function. Question 11. A 55-year-old carpenter presents with gradual onset of pain at the lateral epicondyle, exacerbated by gripping and resisted wrist extension. Which of the following is the most appropriate initial intervention? A. Surgical debridement of the extensor tendons. B. Corticosteroid injection. C. Counterforce bracing and activity modification. D. Immediate progressive strengthening of wrist extensors. Answer: C. Counterforce bracing and activity modification. This question describes symptoms consistent with lateral epicondylitis, tennis elbow, an overuse injury affecting the common extensor origin. The concept tested is the appropriate initial conservative management strategy for this condition. The keywords gradual onset of pain at the lateral epicondyle, exacerbated by gripping and resisted wrist extension, strongly suggest tendinopathy. Initial treatment for lateral epicondylitis focuses on pain reduction, reducing repetitive strain, and promoting healing. Counterforce bracing helps diffuse stress away from the epicondyle, and activity modification, example altering grip, reducing repetitive movements, is crucial to prevent further irritation. Surgical intervention and corticosteroid injections are typically considered after conservative measures have failed, and immediate progressive strengthening would exacerbate inflammation. For example, advising the carpenter to use tools with larger grips or to take frequent breaks can significantly reduce symptoms. Always begin with conservative, non-invasive approaches to manage overuse injuries. Question 12. A patient with a severe crush injury to the hand develops shiny, taut skin, disproportionate pain, increased sweating, and significant stiffness, leading to limited active and passive range of motion. These symptoms are characteristic of which condition? A. Compartment syndrome. B. Raynaud's phenomenon. C. Complex regional pain syndrome, CRPS. D. Tenosynovitis. Answer: C. Complex regional pain syndrome, CRPS. This question describes the classic constellation of symptoms associated with complex regional pain syndrome, CRPS, a chronic pain condition that typically affects an arm or leg. The keywords are crucial here: shiny, taut skin, disproportionate pain, pain out of proportion to the injury, increased sweating, and significant stiffness are all hallmark signs of CRPS, indicating autonomic, sensory, and motor dysfunction. Compartment syndrome is an acute, emergent condition involving pressure buildup. Raynaud's phenomenon involves vasospasm in response to cold or stress. Tenosynovitis is inflammation of a tendon sheath. Recognizing the specific combination of sensory, motor, and autonomic changes is key to identifying CRPS, a condition that requires early and aggressive management to prevent long-term disability. Question 13. A therapist is evaluating a patient with carpal tunnel syndrome symptoms. To objectively assess the level of sensory deficit, which standardized test is most appropriate? A. Dynamometer pinch test. B. Volumetric displacement. C. Semmes-Weinstein monofilament test. D. Two-point discrimination. Answer: C. Semmes-Weinstein monofilament test. This question assesses knowledge of objective sensory evaluation tools, specifically for conditions like carpal tunnel syndrome which affect nerve compression. While both Semmes-Weinstein monofilament testing and two-point discrimination assess sensation, the Semmes-Weinstein monofilament test is considered the gold standard for objectively quantifying diminished protective sensation and nerve compression. It uses monofilaments of varying thickness to determine the threshold of touch perception, providing a more detailed and quantitative measure of sensory loss compared to two-point discrimination, which assesses innervation density. Dynamometer pinch tests measure strength, and volumetric displacement measures edema. For example, a patient with carpal tunnel syndrome might perceive the 2.83 monofilament but not the 3.61, indicating a diminished light touch sensation. Always prioritize the Semmes-Weinstein for a precise and quantitative assessment of nerve compression and protective sensation. Question 14. A patient sustained a type 1 mallet finger injury. What is the recommended treatment for this condition? A. Surgical repair with K-wire fixation. B. Immobilization of the dip joint in slight hyperextension for 6 to 8 weeks. C. Immobilization of the PIP joint in full extension for 4 to 6 weeks. D. Immediate active range of motion of the dip joint. Answer: B. Immobilization of the dip joint in slight hyperextension for 6 to 8 weeks. This question tests knowledge of common finger injuries and their standard management. A type 1 mallet finger is an avulsion of the extensor tendon from its insertion at the base of the distal phalanx, resulting in an inability to extend the dip joint. The concept of mallet finger means the fingertip drops. The standard conservative treatment involves continuous splinting of the distal interphalangeal dip joint in slight hyperextension, 0 to 15 degrees, for 6 to 8 weeks, without allowing any flexion of the dip joint during this period, to allow the extensor tendon to heal. This immobilization prevents the disrupted tendon from being restretched and promotes healing in the correct position. Surgical intervention is typically reserved for larger avulsion fractures or chronic cases, and early active motion would prevent healing. An example is using a stack splint or a custom orthosis to keep the dip joint extended. Continuous immobilization of the dip joint is critical for successful healing of a mallet finger. Question 15. A therapist is instructing a patient on scar massage techniques following a dorsal hand laceration repair. What is the primary purpose of scar massage in this context? A. To increase tensile strength of the scar. B. To break up collagen fibers and promote pliability. C. To accelerate wound closure. D. To desensitize the area to light touch. Answer: B. To break up collagen fibers and promote pliability. This question focuses on the principles and benefits of scar management. The concept being tested is the purpose of scar massage during the healing process. The primary purpose of scar massage is to soften and mobilize the developing scar tissue, particularly by breaking down adhesions and promoting proper alignment of collagen fibers. This helps to improve the scar's pliability, reduce stiffness, and minimize adhesions to underlying structures. While it can contribute to desensitization over time, its main mechanical effect is on collagen remodeling and pliability, not accelerating wound closure or directly increasing tensile strength in the early stages. For example, massaging a thick, rope-like scar on the hand can significantly improve the patient's range of motion and comfort. Remember, scar massage is key to improving tissue mobility and preventing restrictive adhesions. Question 16. A patient presents with a subluxation of the extensor carpi ulnaris (ECU) tendon, often caused by repetitive forceful supination and pronation, particularly with wrist ulnar deviation. Which of the following is the most appropriate initial intervention? A. Immobilization in a short arm cast. B. Surgical repair of the ECU sheath. C. Strengthening exercises for the wrist extensors. D. Resting orthosis with the wrist in slight extension and radial deviation. Answer: D. Resting orthosis with the wrist in slight extension and radial deviation. This question tests knowledge of ECU subluxation and its appropriate conservative management. The keyword subluxation of the extensor carpi ulnaris, ECU, tendon, and the mechanism of injury, repetitive forceful supination/pronation with ulnar deviation, are key. The goal of initial conservative treatment is to stabilize the tendon and prevent further subluxation by positioning the wrist in a way that minimizes the tendency for the tendon to pop out. Immobilizing the wrist in slight extension and radial deviation tightens the ECU sheath, thereby holding the tendon within its groove and reducing the chance of further subluxation, allowing the sheath to heal. Strengthening exercises would be too aggressive initially, and surgical repair is a later consideration if conservative treatment fails. For instance, a custom thermoplastic orthosis can achieve this precise position. Remember to immobilize in a position that maintains reduction of the tendon. Question 17. A therapist is evaluating a patient with a proximal interphalangeal (PIP) joint contracture of 45 degrees. The joint has a firm end feel. The goal is to improve passive extension. Which type of orthosis is most appropriate? A. Static progressive orthosis. B. Dynamic orthosis. C. Resting orthosis. D. Articulated elbow orthosis. Answer: A. Static progressive orthosis. This question tests understanding of different orthosis types and their application for joint stiffness. The key phrase PIP joint contracture of 45 degrees with a firm end feel indicates a significant, possibly more established contracture that requires a consistent, sustained stretch. A static progressive orthosis is ideal because it applies a constant, low-load stretch that can be gradually adjusted by the patient or therapist over time, effectively remodeling collagen and improving range of motion for stiff joints with a firm end feel. A dynamic orthosis uses rubber bands or springs for continuous low-load stretch, but static progressive often provides a stronger, more direct pull for firm contractures. A resting orthosis primarily provides support, and an articulated elbow orthosis is for the elbow, not the finger. For example, a turnbuckle orthosis applies a precise, adjustable stretch to the stiff PIP joint. Choose static progressive orthoses when a firm end feel indicates significant tissue shortening needing sustained, adjustable tension. Question 18. What is the primary purpose of a blocking orthosis or dorsal blocking orthosis in the early rehabilitation phase after a flexor tendon repair? A. To prevent active wrist extension. B. To limit full digital extension at the MCP joints. C. To promote isolated FDS or FDP gliding. D. To increase passive range of motion. Answer: B. To limit full digital extension at the MCP joints. This question focuses on the critical role of orthoses in postoperative flexor tendon repair protocols. The primary concept tested is the function of a dorsal blocking orthosis. The purpose of this orthosis is to prevent excessive extension of the metacarpophalangeal (MCP) joints, typically blocking them at 30 to 40 degrees of flexion, while allowing full flexion. This position helps protect the healing flexor tendon repair from rupture by preventing an overstretch, especially during early active motion, while still allowing controlled flexor tendon gliding. It does not primarily prevent wrist extension, promote isolated gliding, or increase passive range of motion. For example, by keeping the MCP joints slightly flexed, the orthosis ensures that the repaired flexor tendons are not overlengthened during guarded active flexion exercises. The dorsal blocking orthosis is essential for protecting the integrity of the flexor tendon repair in its vulnerable early stages. Question 19. A patient with osteoarthritis of the thumb carpometacarpal (CMC) joint reports significant pain with pinch activities. Which orthotic design is most appropriate to reduce pain and provide support during functional tasks? A. Thumb spica orthosis, long opponens. B. Resting hand orthosis. C. Dorsal blocking orthosis. D. Thumb spica orthosis, short opponens. Answer: D. Thumb spica orthosis, short opponens. This question evaluates the understanding of orthotic intervention for specific joint pathologies. The concept tested is the proper orthotic choice for thumb CMC joint osteoarthritis. The key phrase osteoarthritis of the thumb carpal CMC joint causing significant pain with pinch activities points to instability and inflammation at the base of the thumb. A short opponent's thumb spica orthosis is specifically designed to immobilize or support the thumb CMC joint, reducing pain by limiting excessive motion and providing stability, while still allowing for wrist motion and some finger use. A long opponent's orthosis includes the wrist, which might not be necessary or desirable for isolated CMC pain. Resting hand and dorsal blocking orthoses are used for different conditions. For example, wearing a custom-molded short thumb spica orthosis can significantly reduce pain and allow a person with CMC OA to perform daily tasks like opening jars with less discomfort. When treating thumb CMC OA, think short thumb spica. Question 20. A patient presents with acute onset pain, redness, swelling, and tenderness at the base of the thumb on the palmar side, with a positive Froment's sign. This presentation is most consistent with which condition? A. De Quervain's tenosynovitis. B. Trigger thumb. C. Intersection syndrome. D. Gamekeeper's thumb. Answer: B. Trigger thumb. This question assesses knowledge of specific hand pathologies and their characteristic clinical presentations. The keywords acute onset pain, redness, swelling, and tenderness at the base of the thumb on the palmar side and the specific location are crucial indicators. While a positive Froment's sign is associated with ulnar nerve palsy, it's a distractor here. The primary symptoms strongly point to trigger thumb, stenosing tenosynovitis of the FPL tendon. This condition involves inflammation and thickening of the A1 pulley and flexor pollicis longus, FPL, tendon, causing a painful catching or locking sensation during thumb flexion and extension, often felt as a tender nodule at the base of the thumb. De Quervain's is at the radial wrist, intersection syndrome is on the dorsal forearm, and gamekeeper's thumb is a UCL injury. For example, a patient with trigger thumb often reports that their thumb catches or locks when they try to straighten it. Focus on the direct presentation of pain and tenderness at the base of the thumb. Question 21. A patient with a radial nerve injury at the spiral groove is being evaluated. Which functional activity would be most significantly impaired? A. Holding a pen for writing. B. Bringing food to the mouth. C. Opening a jar with both hands. D. Reaching overhead. Answer: A. Holding a pen for writing. This question tests the functional implications of a radial nerve injury, specifically at the spiral groove, midhumeral level. The concept is understanding the motor deficits caused by this injury and how they impact daily tasks. A radial nerve injury at this level results in a wrist drop, meaning weakness or paralysis of the wrist and finger extensors. Holding a pen for writing requires stable wrist extension and controlled finger extension, both of which are severely compromised with a radial nerve palsy. Bringing food to the mouth primarily involves elbow flexion and shoulder motion, biceps, deltoid. Opening a jar involves grip and forearm rotation, often requiring strong wrist extension as a stabilizer, and reaching overhead involves shoulder muscles. While opening a jar would be affected, the direct inability to stabilize the wrist in extension makes writing extremely difficult. For example, without the ability to extend the wrist, the hand collapses into flexion, making precision tasks like writing challenging. The lack of active wrist and finger extension directly impacts precision tasks. Question 22. A patient presents with a laceration to the thenar eminence. During evaluation, the therapist notes a loss of palmar abduction of the thumb. Which muscle is most likely affected? A. Flexor pollicis brevis. B. Adductor pollicis. C. Abductor pollicis brevis. D. Opponens pollicis. Answer: C. Abductor pollicis brevis. This question tests specific muscle anatomy and function, particularly for the thenar group. The key phrases are laceration to the thenar eminence and loss of palmar abduction of the thumb. Palmar abduction is the movement of the thumb away from the palm, perpendicular to the palm's surface. The abductor pollicis brevis, APB, is the primary muscle responsible for this motion, and it is part of the superficial layer of the thenar eminence. While opponens pollicis aids in opposition, a combination of abduction, flexion, and rotation, the APB is the main abductor. Flexor pollicis brevis primarily flexes the MCP joint, and adductor pollicis adducts the thumb. For example, if a patient cannot bring their thumb straight up from the palm to pinch a large object, injury to the APB should be suspected. Always recall the specific actions of the thenar muscles to determine which is affected by a particular functional loss. Question 23. A patient underwent a flexor digitorum profundus, FDP, repair in zone I. What is the primary purpose of early active motion protocols in this zone? A. To prevent rupture of the repair. B. To promote strong grip strength immediately. C. To minimize adherence of the tendon to surrounding tissues. D. To achieve full passive range of motion quickly. Answer: C. To minimize adherence of the tendon to surrounding tissues. This question focuses on the rationale behind early active motion protocols in flexor tendon rehabilitation, specifically for zone I. The concept tested is the balance between protecting the repair and promoting healing. While preventing rupture is crucial, the primary reason for early active motion is to promote tendon gliding and minimize adhesions, scar tissue sticking to the tendon. Motion helps the tendon slide within its sheath, preventing it from getting stuck and allowing for better long-term functional outcomes. Immediate strong grip strength is not a goal, and full passive range of motion should be achieved gradually and cautiously to protect the repair. For instance, gentle active flexion and extension exercises help the FDP tendon glide past the A5 pulley and reduce stiffness. Remember that controlled motion is key to preventing adhesions after tendon repair. Question 24. Which of the following conditions is characterized by a positive Tenel sign at Guyon's canal and weakness in intrinsic muscles of the hand, excluding the thenar group? A. Carpal tunnel syndrome. B. Cubital tunnel syndrome. C. Guyon's canal syndrome. D. Radial tunnel syndrome. Answer: C. Guyon's canal syndrome. This question tests specific nerve entrapment syndromes and their characteristic signs. The keywords positive Tenel sign at Guyon's canal and weakness in intrinsic muscles of the hand, excluding the thenar group, are definitive indicators of Guyon's canal syndrome. Guyon's canal is the anatomical space at the wrist through which the ulnar nerve and artery pass. Compression of the ulnar nerve here can affect the motor branch supplying the intrinsic muscles, like interossei, lumbricals to the ring and small fingers, hypothenar muscles, adductor pollicis, and or the sensory branches to the small finger and ulnar half of the ring finger. Carpal tunnel syndrome involves the median nerve, cubital tunnel syndrome involves the ulnar nerve at the elbow, and radial tunnel syndrome involves the radial nerve in the forearm. For example, a cyclist who experiences numbness and weakness in their small finger after long rides might be developing Guyon's canal syndrome due to prolonged pressure on the ulnar nerve. A positive Tenels at the wrist, combined with intrinsic hand weakness, points strongly to Guyon's canal involvement. Question 25. A patient is being fitted with a custom thermoplastic orthosis for a chronic wrist extension contracture. The therapist is applying low-load prolonged stretch. What is the physiological principle behind using this type of force to remodel connective tissue? A. Wolff's law. B. Stress relaxation. C. Creep. D. Hooke's law. Answer: C. Creep. This question delves into the biomechanical principles governing tissue remodeling in response to applied force. The concept being tested is the effect of low-load prolonged stretch on connective tissue. Creep is the physiological principle where connective tissue, when subjected to a constant load, like a prolonged stretch from an orthosis, will slowly and progressively deform over time, resulting in increased length. This gradual elongation helps to remodel collagen fibers and reduce a contracture. Wolff's law relates to bone remodeling. Stress relaxation describes how stress decreases over time when tissue is held at a constant length, and Hooke's law describes the linear relationship between stress and strain within the elastic limit. For example, maintaining a sustained stretch on a stiff joint with an orthosis for several hours allows the joint capsule and surrounding soft tissues to slowly lengthen. Understanding creep is fundamental to effectively treating joint contractures with orthoses.